Sean, I'm going to have you run my slides. Thank you very much for doing that. So for me, as Sean said, I'm an associate professor. I did a fellowship in sports medicine and adult knee reconstruction. So let's go to the next slide if you don't mind, Sean. So kind of here's the total hip case. So this is actually one of my colleagues' total hip case, and I thought it was really interesting. So if you look at these two x-rays, you look at obviously superior wear, there's quite a bit of posterior wear as well coming in. And interestingly enough, when my colleague got in there and he did intraoperatively, when he started to kind of look in the next processes, what he noticed on the pre-op x-rays, if you can kind of zoom into them, you can see how the femoral head is starting to flatten out. You have superiorization, and you kind of have this cystic lesion also taking place in the acetabulum. So when my colleague was reaming, he found a cystic lesion, and he thought to himself, well, you know, I'm going to put a screw for fixation, but what about that void that I typically can have? And one of the things that we kind of think about, right, is if you're doing a total hip case, sometimes when you're doing a liner exchange and you have some of the osteolysis behind your holes, what do you do with that aspect? And if you go to the next slide, Sean, so here's actually a 6-week x-ray, and this is what I thought was really interesting on this platform, is kind of, here's again a kind of a close-up view, and you can kind of see the cyst just medial to where the wear is on the femoral head in this x-ray. You can see a little bit of that wear correctness of the cyst. So Sean, next slide, please. So here's a nice x-ray of the post-op x-ray. So kind of ironically, one of my colleagues goes, hey, well, look, that's not a good x-ray, Nirav. You can't see where I put the bone graft in. You can't see anything post-operatively. And I go, hey, that's the point. If we're 6 weeks out and we can't see our bone graft, obviously the cup is some of the anteversion of the cup is hiding some of the cystic lesions. But you can see that. And Sean, next x-ray. And here's kind of a little image. So you can see a little bit of the bone graft in there. It's really hard to see, and I know that. But if you kind of moving the x-ray a little bit, you can see a little bit of where the screw head is right there, Sean, where you're just pointing where the screws kind of takeoff point is. And that's where some of the, we used almost 5 cc's of bone graft in that region. So I think it has a nice validity or application in some of these cyst type cases. So kind of my ground base, I'll go to the next slide now. So ironically today, I know some of the gentlemen have not had the opportunity to start operating. So we have started in California to start operating. So I had this patient kind of patiently waiting. Here's an Acl reconstruction. Here's an AP and lateral x-ray. You can see on the lateral x-ray, the femoral fixation may be a little bit anterior and missing a little bit anterior, as I say, to residence ridge. But the tibial tunnel looks a little bit anterior, but you can see on the lateral x-ray that it may be a little bit dilated as well. So for this case, because the patient's femoral tunnel was anterior to the primary location, I actually used low-profile AM reamers. And then I did an all-quad tendon I did a bone tendon bone ACL, and my logic was bone-to-bone healing and then upsize the screw on the femoral side, on the tibial side to help with the fixation. So if you go to the next slide, Sean. And here's kind of the images. So I'll just kind of walk you through them. So there's my patellar defect for my bone harvest. And if you look really closely, you'll see a couple of the little bone chips. And what I normally do is I'll actually always take some bone chips from the tibial side. And Sean and Scott, you can allude to and comment on this as well. I normally will take some bone graft from my tibial harvest side and move it up to the patellar side. And then what I do, if you look on the image there, right, I filled it with the NanoBone. So you see the NanoBone kind of packed in there. I actually just use 1 cc, and 1 cc is plenty for this application. And if you look on the far right image, what I did is I packed my tibial harvest side as well. It actually leaves you enough if you just use a 1 cc bone harvest. So for me, it's a great application in this way. And my logic for me on my patellar tendon VTB autografts is to prevent a patella fracture from happening. And anyone who watches football knows that Jerry Rice had a patella fracture status post VTB 4.5 months after coming back to the NFL. So for me, that's kind of my application of the NanoBone in my practice. And I have started to expand it a little bit more. As you'll see, Gil is going to have some excellent information for us and navigate a lot more scientific base on the trauma realm. So as Sean said earlier, all of us, liking it or not liking it, being traumatologists, I have expanded my repertoire in the last probably month or so. So I'll hand it back to you, Sean. Thank you very much.
So, Nirav, you covered some interesting stuff there, and I kind of want to touch on being selfish as a sports guy. Let's start with the sports stuff. So, you mentioned that you'll use 1 cc of the NanoBone to go back and fill in the defect on your patella and your tibial site. Are you reconstituting this with blood or anything, or you're just putting this in here and letting it go?
Yeah, so Sean, that's the interesting thing, right, about this nanobone technology and the data. So this application of the bone graft historically has been used in over 400,000 cases back in Germany. And ironically, they have not admixed. So I think that's the big difference between this bone graft technology and other bone grafts.
Oh.
I'll take over. You really don't want to put much blood in this. You want to keep it right out of this, and just put it right into the defect, right out of the delivery system, and it will heal in real quickly. The concept of the concept is it just really increases the surface area of these crystals, so that bone growth can grow in. And I know Gil's going to hit all over that in his talk.
Scott, when you do your ACLs, your BTBs, are you typically filling in your defect, or is it something you started doing as you've gone through your practice?
Yeah, for all my bone defects, I'm filling it in using this technology, and I've actually started using it for my revisions as well. It just heals so much quicker than cancellous chips, and is a lot easier. And it's unlike some of the other putties that kind of dissolve with water. This is arthroscopy, resilient in arthroscopy, and you'll be able to get where you need to be without it kind of just going everywhere.
So when you think
Sean,
about
sorry, Sean, I think you couldn't hear me, but I'll echo Scott's comments a little bit earlier. I mean, it's brilliant. You don't have to admix it with a BMAC or a umbilical cord or all PRP or all these other constitutes. And I echo his statement also. It doesn't wash away. Its material and handling is phenomenal.
All right, so Scott, we're going to go back to something you said earlier about your tunnels on your ACL. When you were grafting, typically when you were doing a cancellous chips, what was your timeline for a patient? What would you tell them? You're going to get radiographs serially, you're going to get a CAT scan, you're going to wait, 6 months. Has that changed now using the NanoBone or the grafting techniques that you're doing now?
Yeah, I mean, this bone, you start seeing basically fill-in of the bone at 6 weeks. I'll show you on my case and some of the osteotomies. And so I think you're probably safe in going back at 3 months.
Gotcha. And you're doing CAT scans or X-rays. What are you doing to sort of, get your sort of?
X-rays, and you can see, it is pretty remarkable how quick the bone will fill in.
Gotcha. And if you could jump in for Nirav, just because I know he's in a bad cell area right now. With your total hips, are you grafting ever when you're getting sort of those shallow acetabulums?
That's an interesting kind of concept. I've never applied that in my total hips. I do a lot of hip preservation. So I do use about the 10 cc volume in our PAOs. And then if we're doing a proximal femoral with the PAO, we'll use 220, which is, 210s.
Any thought to considering this in like an AVN picture?
That's a concept that we're looking at right now. I think it certainly has a lot of potential. One of the key things though is this doesn't just heal without blood flow. So if you don't heal the primary problem with AVN of return to blood flow, then it may not work as well. But we've tried in a number of patients and we're just following them. So far we have great results.
Gotcha.
So, Sean,
yeah, go ahead. Yeah, please.
Only a couple of cases, but still doing the decompression for the hip and then following it with the NanoBone. So same as that, just following them to make sure they heal in. So,
gotcha. Scott, if we can move on to one of your cases now, you were going to talk about distal femoral osteotomies, and this is an area where I know I've been burned before with HTOs and different sort of bone substitutes. This is something that's really changed your practice, you were saying, correct?
Yeah, I mean, this is just remarkable how fast these things are healing. Like talk about being burned. I look forward to talking about listening to Gil's talk, and then we can come back to